We just have a few more minutes left, and Mike, I want, in every other disease type, they spent the entire time talking about immuno-oncology. We still have something to talk about, and just remind everybody where we are with approvals in colorectal cancer and where you see the field going.
Well, obviously with MSI-high cancers in general, we have pembrolizumab for MSI-high colon, nivolumab plus ipilimumab. The data is very consistent from study to study that MSI-high benefits.
So if you knew that right from the beginning, what line of therapy?
Well, yeah, so right now, of course, the approvals are based on people who have been previously treated, so there might be insurance challenges. The second thing is we don't really know in the first line necessarily how it's going to compare with chemotherapy. That's being tested right now. And you already know what's going to happen in Keynote 177?
I care about the study, but I don't care at the same time because, in all frankness, I've had patients that have never seen a drop of chemotherapy for 5 years.
Yeah, but these are patients from your study. They're Lynch patients.
No, I totally get it. For many patients, they may not even need that chemotherapy.
Yeah. But Mike's point is that the approval was in patients who had had all the prior treatments. So are you going to give them regorafenib before you're going to give them a checkpoint inhibitor if you knew their MSI status? I mean, where do you draw the line? Your argument is front line?
I would say at least one prior line. I think the approvals would say essentially two,
I'd
some
say
prior
actually
therapy.
no more than one line of therapy if you can't afford it.
If you can get it approved.
Now the other thing though is true is it would appear that the response rates are a little better if it's given earlier.
Frontline.
Right,
there was
exactly.
That interesting data.
Yeah, so that would argue for why not do it frontline.
But so mind you that
And
response
there's even data in the neoadjuvant setting for colon, so that's impressive.
But
as
I
well.
think response rate is a bit deceiving with chemo versus PD-1 because a lot of the responses continue to convert over time with the PD-1 inhibitors. With chemo, they actually tend to be fleeting, short-lived. I mean, whatever you call short-lived, it could be 10 months or a year for those patients. Whereby for those with PD-1 inhibitors, MSI high, they continue to have that depth of response, which is probably just that tumor that continues to shrivel.
But for our excitement on one side, there are some patients either who develop toxicities that are significant and have to come off, and not everybody responds. But let's talk about that's the unusual MSI patient. Let's talk about the more common. Kathy, I'll pick on you. What are the efforts going on now to try and convert MSS patients?
I mean, I think there's a lot of interesting data looking at the role of tumor mutation burden. And granted, that is a very small percentage of patients, but there appears to be some positive data that there may be a correlation and you may benefit potentially.
And the only way you're going to get that is through a broader next-gen kind of approach. So arguing back to our original discussion about doing that.
Correct.
So you know that. But is that one of those things, if you had a patient with a TMB of, I'll make a number of 22, but MSS, you calling the Aetna guy to see if you can get it approved?
I think it's not unreasonable if you're running out of options for that patient as well, and they still have a good performance status.
The interesting thing is, though, even in the MSI, and even in the MSI high patients, where there's been a suggestion that even their tumor mutational burden may separate patients, the separation occurs at something like 30 to almost 40 mutations. So it's I think the patient that has 8, 9, 10, 12, it's hard to say that person's likely to...
Wasn't the 80405 data, though, based upon greater than 8?
Well, right, and that's prognostic data. So people, but you're right, even at 8. Now, how you get to these numbers, I mean, often it's the median that's chosen.
Exactly.
With the MSI high...
this is the one you like to draw a line onto because it looks nicer on a publication. Who knows right now? This is
so what the burden should, what should be the cutoff?
Yeah. We published some data. Mo Salem was the lead author that looking at the different MSI missing proteins, mismatch repair proteins, and showing that there are different tumor mutational burdens depending on which ones you're missing. So they're all not even created equally. So we're going to start to subdivide those. Is there a role, Dustin, ever to throw that Hail Mary, that patient who refractory, still good performance status, MSS, should I just try some checkpoint anyway, or is that really a foul?
I think that's a foul. In my mind, the odds of benefit for that patient are extremely low. I would much rather look for a clinical trial for that patient than
Or nothing
than
wrong
try
with
that.
just calling it quits at that
Right.
point,
You're
frankly.
saying, no,
So
no.
why not?
And
I
then-
mean, you know, we know from studies that if you, when the time is right, and if you initiate the palliative care, comfort care option sooner rather than later, those patients actually end up, you know, passing when they get to that point with more dignity and more comfort than if we keep on hammering them down because we just don't want to give up. In fact, you're giving up on them a different way.
I think you're talking about going off on a completely different tangent.
No, that's the Hail Mary effect. Actually,
Yeah.
it's not a completely different agent. A Hail Mary effect is essentially when you don't have any other option and you say, I'm going to try immunotherapy, when the patient is actually...
But I agree. I wouldn't do immunotherapy either. I'm just saying that obviously I think all of us would agree that you should consider palliative care early on in all patients.
No. I'm talking about palliative care as part of the end-of-life care. So that's hospice care, comfort care, not necessarily palliative care, because chemotherapy all the way through is palliative for most of these patients anyways.